Well, hello, we're all settled in. Welcome to this month's research seminar series, The Psychology of Brain Injury and Wellness. My name is Deanna, and I'm the new program assistant for the BC Brain Wellness Program, and will be serving as your MC for today's event. We are joined today by our special guest, Maya Libben, an associate professor of psychology and lead investigator of the Plan Lab at UBC Okanagan, who will be sharing about the interplay of traumatic brain injury, TBI, with emotional function, particularly in the context of women. Before we get started, I'd like to first acknowledge that the BC Brain Wellness Program at the Javad Moafajian Center for Brain Health is situated on the traditional, ancestral, and unceded territories of the Musqueam peoples. As a settler here, I want to remind us all of the important relationships we have with the Indigenous peoples and the land, and to further honor these relationships moving forward. It's important to recognize we have the opportunity to provide these amazing programs like the BC Brain Wellness Program on the Musqueam land. As all of you are joining from different places today, I encourage us all to take a moment to reflect and learn about the history of your land that you occupy, which can be explored through this resource in the chat just sent in over there. And I would also like to take a moment to thank all of our program donors for supporting the BC Brain Wellness Program. Because of your generosity, we are able to provide these educational events in our online classes, creating accessibility to anyone and everyone. As an entirely donor-funded program, we rely on your generosity to ensure the continuation and development of our program. So thank you for your ongoing support. So without further ado, I will pass on the Zoom mic to our guest speaker. The floor is all yours, Dr. Libben. Welcome.
Thank you, Diana. Much appreciated. So it's so nice to be here. Thank you for the invite and to virtually meet all of you. Today, I'm actually joining you from Ottawa. So I am on the unceded territory of the Anishinaabe, Algonquin Nation. And my lab, as Diana mentioned, is at UBCO in Kelowna, which is the unceded territory of the Syilx Okanagan Nation. And so grateful to be coming to you from kind of both of those places. So my background is in neuropsychology, as well as clinical psychology. And I thought today we'd kind of talk about the intersection between the two, which is an interest of mine of kind of how do people with injury due to all sorts of causes. Today I'll talk about traumatic brain injury, but I'm interested in kind of the vast area of neuropsychology, including mostly TBI and stroke, as most of my research. And so although I'll be focusing on TBI today, a lot of what I talk about is applicable to neurocognitive function in general. And so I'll be looking a little bit at the emotional function in these individuals. All right. So the title of my talk today is Psychological Treatment for Brain Injury. We'll talk about some of the current approaches, as well as some of the research that we've been doing for future growth in this area. And let's see here, there we go. So as I mentioned, my lab is at UBCO in Kelowna. And none of what I would talk about today or what I'm going to talk about today would be possible without my wonderful graduate students. And so who all make up part of the Plan Lab, and that stands for the Psychopathology, Lifespan, and Neuropsychology Laboratory. So again, we kind of look at clinical issues, we look at lifespan issues with a focus on the psychology of the brain. And so today I am going to focus on traumatic brain injury, which is a focus of my laboratory research as well as my clinical practice. So I do clinical work about 1 to 2 days a week. So kind of more on the psychotherapy and assessment front. And the big thing with TBI and a lot of other brain conditions, stroke being a great example as well, is that one day your whole life changes, really quite drastically, and in immeasurable different kinds of ways. And then these lead to, these chronic conditions that affect the rest of your life. And so how do we cope with that change? How do we adjust to that change? How do we still live a full and meaningful life in the wake of this change that we weren't expecting, right? And so when we look at TBI, there's a number of different types of symptoms that tend to come up. And again, a lot of these are overlapping with other neurological conditions, but we get physical symptoms, which include things like dizziness, headaches. You get a lot of sensitivity to both noise and to light, high levels of fatigue. There's usually quite a bit of pain, as well as visual issues. We get cognitive symptoms, again, similar to other neurocognitive disorders, issues with memory, concentration, problem solving or executive function. Things kind of slow down a bit. People often have memory issues, as well as just trouble in general thinking. So kind of what we call more generally brain fog. And then there's often sleep issues, right? So sleeping too much or too little, right? Difficulty falling or staying asleep. And this all kind of translates into fatigue in the day-to-day function. And then finally, there's the emotional piece, right? And that really comes very often from this adjustment to change, right? And these feelings of loss, of you were living one type of life one day, and then the next day you're living a completely different kind of life. And this can present as anxiety, as depression, or irritability. With traumatic brain injury in particular, we often see post-traumatic stress disorder, because often these injuries happen in things like car accidents, right? You might see personality changes depending on the part of the brain that might have been injured, as well as impulsivity. And so today what I'd like to talk about is just kind of some of these psychological symptoms that we see in TBI and in other neurocognitive disorders in general. We'll talk a little bit about gender and sex differences in TBI in terms of prevalence and kind of outcomes for both men and women and kind of across the spectrum. And then mostly today, I'll talk about treatments. So are there specific treatments for things like anxiety and depression in neurological disorders, right? What makes them maybe different, what makes them more effective, and what makes them less effective? Okay. So traumatic injury has a pretty high prevalence rate. And so we're looking at about 500 out of every 100,000 individuals, right? And so that's kind of 165,000 in Canada, right? Equates to about 456 every day, right? Or as as we finish this talk, probably about 20 people just in Canada alone. And within TBI, we do see a really high rate of psychological disorders. And so there's some big ranges there in the percentages. And that's because there's different ways of measuring these, right? Different populations. And so we see quite a bit of variance in the research. But we're looking at like 20 to 60% of people with TBI suffer from depression. 20 to 70 with anxiety, and then a little bit lower because it depends on the nature of how you got the TBI with post-traumatic stress disorder. What we do find is that psychological factors, right? So whether or not you have these types of conditions really play a significant role in overall recovery from TBI and just functional outcome. So how do you function in your life in general? So it is an important topic, both because TBI is very prevalent, right? And because there are a lot of psychological disorders in TBI. So what tends to predict psychological disturbance after having a traumatic brain injury, right? So not everybody has things like depression, like anxiety after a TBI, similar to not everybody has these conditions after a stroke, with a diagnosis of Parkinson's, right? A lot of the things that have been covered in this lecture series. And so for TBI, what we know is that if you have a history before the injury of something like depression or anxiety, it is more likely that this will kind of reemerge after the injury. So it's more likely to come back. If you have multiple brain injuries, much more likely. Multiple tends to be not a good prognostic indicator for traumatic brain injury. So you're much more likely to have emotional difficulties if you've had more than one concussion, moderate TBI, or severe TBI. Poor physical functioning, and particularly whiplash disorder, which is interesting. So if you experience a whiplash, which is very common, because if you think about a traumatic brain injury, I should have mentioned this at the beginning, but what traumatic brain injury comes from some kind of direct or indirect force to the head. So either something hits you against the head, right, shakes up your brain, or it might be a velocity thing. So for example, a car accident is a good example of your head gets shaken like that, right? And so if your head goes like that, the chances of you hurting your neck are really pretty high. And we're going to talk about sex and gender in a bit, but of course for women, it's actually higher because we have smaller necks. So the chances of you experiencing a whiplash when you experience a TBI are really quite high, especially if you're female. Individuals who are younger and experience a TBI are more likely to experience depression, while older age seems to be more associated with the onset of anxiety. And like I said, we'll talk about gender differences, but being female is a risk factor for psychological disturbance after TBI. So we'll talk about how men are actually more likely to get a TBI, but women tend to get more of this kind of psychological disruption in their picture. Not having good social support, right, really is not a great indicator. And then if you have damage to the frontal areas of your brain, this tends to predict personality changes, as well as emotional disruption in general, just because those frontal lobes are very important for our emotional functioning and basically just who we are in terms of our personality. So what does depression kind of look like after a brain injury? It tends to be, feelings of sadness that go beyond normal sadness, right? There may have been loss associated with the TBI, right? And it kind of goes above and beyond that and extends out. There's very poor motivation for getting things done around the house, right? For wanting to do your enjoyable activities. Often when you experience enjoyable activities, feel less pleasure, right? May become disinterested in things, right? Feeling of heaviness, right? Emptiness, kind of that robotic feeling. You might feel bad about yourself, about the future, right? Kind of hopeless after the injury, and a general sense of worthlessness. Okay, so those are kind of things to look out for when we're talking about depression in general. Oops. Yep. And of course, there can be different kinds of depression in TBI, right? So it could be that you had depression in the past and now there's been a relapse, right? Because experiencing any kind of neurological injury is very stressful, right? So you could have a relapse of a depressive episode. You can start feeling depressed because you're not sleeping well, right? So like I said before, TBI does affect sleep. And as you may have noticed at some point in your life, if you don't sleep well, you don't feel good, right? And that can cause a low mood. Hormone dysfunction after a TBI or a stroke, right? Again, same thing with Parkinson's. Depending on the parts of the brain that were affected, you could get some pituitary dysfunction that then affects, things like your thyroid, right? BDNF, and so it can actually be quite biological, that depression. And then sometimes there's more of that kind of grief picture, right? Often after a neurological injury, you've lost a lot, right? Depending on what happened, where it happened. And so this feeling of loss can really begin a grief process where you're grieving maybe who you were before. Okay? So that's kind of the depression picture. And then anxiety, we also have kind of different types. So some people worry a lot, right? In terms of their anxiety after some kind of neuronal injury. So that might be more generalized anxiety subtype. Like I said in the beginning, usually a TBI results in quite high sensitivity to light and noise. And that in itself can actually cause anxiety, right? So people get quite anxious because they feel overstimulated. The environment that they're in is too crowded, right? The voices are too loud or too soft, right? The lights are too bright. And the way that your body responds to that is to try to get you out of that environment. And so your body makes you anxious. Dysautonomia, never can say it. Dysautonomia is a condition where basically your peripheral nervous system gets heightened after a TBI. And so it actually presents very similar to anxiety. It's a little bit different because it's a little bit more biologically based. Some people experience panic attacks after a brain injury. And so it might be associated with certain environments or maybe certain feelings in your body. You start getting quite panicky because a symptom starts, and then you might experience a full-blown panic attack. And then, of course, as I mentioned before, there's post-traumatic stress disorder. So if the injury was sustained in something like a car accident, right, or maybe interpartner violence, right, something like that, then we get this trauma aspect to the disorder. And so it's always tricky to kind of differentiate PTSD in particular from TBI because there's a lot of overlap between the two. And so you can kind of see that in the middle section here, right? So both of them involve irritability, cognitive issues, insomnia, depression, fatigue. TBI has more of these kind of physiological symptoms, so like the headaches and the light and noise sensitivity, right? The vision problems and the dizziness. While PTSD really has more of these psychological ones, like the flashbacks and the nightmares. They tend to avoid certain situations. And so, again, a lot of overlap between these two conditions. But there are some specific features to help you kind of figure out what's happening what's going on. Okay, so that gives you an overview of a very cheery overview of what happens, or what can happen psychologically after a TBI. And so the big question is, are there gender differences, right? And so this slide here, I had a citation on it. It seems to have disappeared, but it's from a 2018 study, I believe. And so you can see you get a big spike right around here of everyone gets more brain injuries when they're about 15 to 24, but especially men. And then, and then it kind of goes down, and then it goes up a little bit at the end here, right, with less gender differences. I think you guys are all forced mic'd, so I won't ask anybody to shout out why they think there might be a spike over here. So I'll just tell you, but over here we see a spike because of car accidents. So new drivers, right? Also young people do silly things. They jump off cliffs, they go cliff diving, they go skydiving, they do all these kind of adrenaline junkie activities, and men do them more, right? And so that's why you see this higher incident up here of males in that 15 to 24 range, right? And then we all become more responsible, and it goes down. And then the spike up here, kind of 75 plus, is due to falls. And so see a higher incident of traumatic brain injury because of falls. Kind of with older age. Okay, but generally we can see that men do experience more TBIs than women. Now, the interesting thing here is what I mentioned before, that women actually psychologically fare worse after a brain injury. So even though they're less likely to get one, they tend to have poorer psychological outcomes. And it's a very mixed bag because you have to look at so many different features, right? So from a biological perspective, there's been some interesting animal studies on estrogen and progesterone in females. And it was actually originally thought to have a protective role in TBI, so to help women recover better after TBI. Now that's actually looking a little bit more mixed in terms of it might be better in the short run, but actually worse in the long run with respect to those hormones. And then we have social factors playing in, right? We've got lifestyle responsibilities, right? The fact that women tend to be more susceptible to anxiety and depression in general, right? Also that women are more likely to seek help, right, when they experience these kinds of symptoms. And so that might also bias our understanding of how prevalent this is in women compared to men. And then same thing over here, right? So you can see like all the different things that you really have to consider when you're looking at some of these data and why it's so messy. There's the physical attributes, right? So the hormones, right? Physiology. I talked about the neck, right? Women are more susceptible to get whiplash just because they have smaller necks. And that's not a great prognostic indicator for TBI, right? You have the gender part of it, right? So the social piece, right? And so are they more likely to ask for help, right? What are the social roles? What are the power and equity roles, right? And then finally, personal and social factors. So it's very much an emerging area of research with respect to gender. And basically there's mixed findings. So you have one study saying one thing, you have another study saying the other thing, okay? And so it's something that's been highlighted, really needs to be investigated in the TBI literature, because there seem to be some strong effects, but we don't really understand in what direction and why these are happening. And that's really important for treatment in the long term, right? So to help people effectively, we do need to know what's causing what. Okay, so if we look at treatment, how do we treat psychological conditions after a brain injury? And then are there kind of methods that might be most effective within this subpopulation? So one first thing that's really important, and I would say this as a psychologist in general, you need to know what you're treating, okay? So we throw around terms like anxiety and depression, right? But someone who is experiencing depression because of a hormone dysregulation, right? So damage to a part of their brain is very, very different from someone who's experiencing depression due to grief, right? Because of a certain loss of self. And so first thing is you really need a proper assessment of what is happening for this individual and kind of what might be at the root of these depressive symptoms. Same thing for anxiety, right? Someone who has trauma is very, very different from someone who is experiencing overstimulation, right? And so part of this field, and again, this relates to psychological function after any kind of neuronal injury, right? It's much more complicated because you got much more going on when you have damage to the brain, right? And so having a really proper assessment of what's going on is so critical and does not happen enough. And so that's kind of my like soapbox spiel, but we need people to have access to better assessments. And then there's some, I guess, tried and true methods of therapy that work across populations. And so one of those is cognitive behavior therapy. You may have heard of it in the past. And the idea here is to kind of target thoughts, right? And so this would be like a TBI example. So maybe you get an increase in symptoms, right? So a headache, for example. So increase in headache, then you get a catastrophic thought. You think, oh no, here comes my headache. This is going to ruin my day. This is going to be so awful. I really wanted today to be a better day. My family's coming to visit me. I can't believe this is happening, right? And so it causes psychological distress. And so it's interesting to note that the psychological distress is coming from your thoughts, right? It's not coming from the headache itself. The headache is causing pain, but it's your interpretation of that pain that's causing you the distress. And then once you have that distress, your sympathetic nervous system comes on, goes into fight or flight. Something terrible must be happening. There must be a tiger around the corner. Let's run, let's go to sleep, let's do something, right? And then with that arousal, now you get more symptoms, right? So now you got adrenaline flowing in your body. And so you get other things, right? You might get some dizziness, you might get some visions symptoms, right? And then it loops around again. So now you have more symptoms. So you're catastrophizing more, and around you go. And so that's kind of how CBT works. And it's largely very effective. But interestingly, more recent research has found that it's less effective for neurological populations than the general population, which has made researchers, including myself, kind of think, is there something else going on here, right? Is there something additional why these kind of tried and true techniques don't seem to be working as well? And so part of it comes down to, again, this statement, right? That these populations are kind of unique in that you have this major life event, and now potentially you as a person are different, right? And adjusting to that change is really, really difficult. And so straight up CBT can kind of get at that, but it may not be the ideal technique to get at that. And so that's some of the research that we've been doing in my lab, is looking at what's called psychological flexibility, right? Can you adjust to change? How good are you adjusting to change? And does that predict how you do after a brain injury? And so psychological flexibility is not a new term. It's just new to this population, right? And so it was kind of coined, I'd say, late 1990s, early 2000. Stephen Hayes is the founder of what's called acceptance and commitment therapy. And he really coined this term. And so the idea here is that flexibility really results in the person being more open and willing to experience despite pain, right? So you're able to pursue your values despite the presence of pain and distress. And so usually psychologically flexible people are less invested in trying to control everything that's going on in their body, right? Be like, I just need to feel, I can do this thing as long as I feel better, right? That's a phrase I hear a lot. I can do this, but I gotta get rid of this headache first. It's, can I maybe still do parts of this with the headache, right? Can I be flexible with this? And so this adapting to change to situational demands, right? Shifting perspectives and kind of finding balance with this new brain that you have, right? That needs a lot more balance. And so can you kind of sit with these uncomfortable feelings, right? Things like pain, right? And acceptance and commitment therapy has been very, very effective for individuals with chronic pain. And like I said, it's kind of, we're stealing it and we're bringing it over to a new population. And so this is a study from Faulkner. They're in Australia, 2020. And they were the first actually to start looking at this. So you can see, again, very, very new. Before 2020, nobody was looking at this in neurological populations. And so the idea here is, I'll kind of walk you through it quickly, but you have these kind of pre-injury risk factors, right? So like I mentioned before, mental health history, personality traits, coping style, right? Are you flexible by nature? And then this influences how psychologically flexible you are. And then you have your brain injury. They looked at MTBI, or mild traumatic brain injury. And they were looking at people who experience persistent post-concussion symptoms. Right? And so basically what they found is that these things really come together to influence how the person functions psychologically, cognitively, how they react to certain pain signals, right? As well as how do they act behaviorally in their environment. And so what they found is that psychological flexibility did play a unique role in terms of recovery outcomes with this population. Again, this is a mild traumatic brain injury. So this is concussion. And so this was above and beyond all the other factors, right? Mental health status, they controlled for everything else, and flexibility really predicted how these people did in the long run. And so how did they do in their relationships, in their stress response, with respect to depression, their post-concussion symptoms. And so this, so we're doing a study right now at Brain Trust in Kelowna. And we've only have 12 people so far. This is my graduate student, Jason Scott. And so he's doing an internship at Brain Trust. And we're looking at, again, mostly mild traumatic brain injury, but kind of across the spectrum. And so this is hot off the press in terms of, we were just looking at this data yesterday, so I thought I'd throw it in here for all of you. And we found a very similar thing. Here we found that, but it's more the inflexibility. So if you're really stuck and this is how it has to be, right? Prognostic outcome went down, right? So basically how much better you've done since your original injury, right? And people were varying. Some people, had a brain injury a year ago, some people was 5, some people are 10, right? But overall, in terms of how you've done and how your symptoms have been since your original injury, went down if you were much more rigid in how you could cope and adapt to different situations. And so we measured this using the acceptance and action questionnaire, which is specifically designed for brain injury. And so I'm just going to talk at the end here just a little bit about flexibility. So as I mentioned, it is rooted in acceptance and commitment therapy. And kind of the main parts are focus on the present, right? So kind of that mindfulness component. Being willing to feel difficult emotions, right? That's a really big one. Difficult emotions don't feel good, and so we don't like them, right? And we want them to go away. And so we do all sorts of things. We are programmed as humans to do all sorts of stuff to make our difficult emotions go away. But if you're willing to allow it to be there, right? You don't have to like it, but if you allow it to be there, it frees you up to do a lot of other things, right? Another one is stepping back from thoughts, right? So as humans, we have thoughts that go through our head all day long. And the funny thing is, if I ask you right now, if you just kind of watch what you're thinking, right? What's going through your head right now, that is a very bizarre thing that we can do, right? So who's watching? So if you're having thoughts and then there's someone watching these thoughts, what's that part, right? And so we as humans, maybe animals can do it too. I don't know. I've never asked one. But we as humans, we know that we can actually do this. So you can sit back and you can watch the thoughts that are going through your head, and you can actually kind of look at those and say, okay, is that helping me? Is that not helping me? And so tapping into that observing self is a big part of acceptance and commitment therapy. And then really identifying your core values, right? So what are the things in life that make you smile, right? That make you feel like you're really connected to the life that you want to live, right? So these aren't goals. It's not something like, I'm going to make a lot of money. I'm going to make $1 million, right? That's a goal. But being successful is value, right? Loving people, right? You can never reach loving people. That's a goal. That's a direction in your life, right? Caring for people, right? It's not that I've cared for 100 people. No, I'm good. I'm a caring person. That's a direction you're taking in your life. And so knowing what these are, and despite the injury, kind of aligning your life so that it meets these values, is a really, really good indicator for how happy you're going to be despite the injury. And so I kind of like this analogy for the stepping back from the thoughts, right? So flexible attention, it means, being connected to the present moment as opposed to being all caught up about the past and about the future. So imagine your thoughts about the future are like a GPS voice, right? It's telling you what's coming up next. But then you become too fixated on that GPS, right? You're not fiddling with the controls, you're adding stops in here, you're checking your arrival time, you're adjusting the volume, right? You're fiddling with all these kind of, again, thoughts. And so you become so focused on this GPS that you lose focus of the road, right? You miss your exit, you nearly rear end another car, right? Make a wrong turn, now you're in a lake. All these things have happened. And so although the GPS is helpful, right? And it's good to listen to it for feedback. You really need to engage in what you're actually doing, right? That present moment, and be mindful of your surroundings. And so that's kind of it's a nice analogy of like how to take your thoughts, right? As we often get really caught up in our thoughts, especially after an injury, like a neuronal injury, right? Around, oh my gosh, like how much have I lost, right? How am I going to cope with this? How am my family going to cope with this? And it's not that those thoughts aren't valid or true, right? That they shouldn't be paid attention to. It's also, but also notice you're still your day-to-day, right? Keep that in mind. Don't lose sight of the road. And then similarly, for accepting difficult emotions, right? And so, as I said, we all have difficult emotions. We don't like them. We want them to go away. They're yucky and they're bad. And so you can really get caught up in a battle with these emotions. So imagine what you're doing with these, again, thoughts, pain, feelings, whatever it is, right? It's like fighting with a ball in a pool. And so if you've ever done this, right, you don't like them, you don't want them, you want them out of your life. And so you try to push this ball under the water to get it out of your consciousness. I don't want it here. But the ball keeps on floating back up to the surface because that's what balls do. So you have to keep on pushing it down. You're holding it under the water, and this is exhausting. It's a really big ball, right? And so you're struggling a lot with this ball, right? And it keeps the ball really close to you. And the whole thing is pretty tiring and futile, right? You're never really going to win this battle. And so if you were able to let the ball go, it would pop up, right? It would float on the surface next to you. You still won't like it, and it'll be annoying. But you can let it float there for a while. You can take off your hands, right? And now, if you free up your hands, you can actually swim, right? You can do all sorts of things, and the annoying ball is still there, but it's possible to do something else, right? And so again, that's kind of what the research is reflecting. If you can have a TBI, right, or a stroke, or whatever it might be, and the symptoms are horrible, right? They're really, really awful. And so there's absolutely no invalidation of that. But can you allow them to be there while also engaging in your life to the best of your abilities, right? And that's more than anyone can ask you to do, right? Is kind of to the best of your abilities, can you do something alongside some of those symptoms? And sometimes the symptoms become too bad, and you can't, right? And that's okay too, right? And so the last thing that I'd kind of mentioned about acceptance and commitment therapy is the values, right? So Viktor Frankl has a great quote, those who have a why to live can bear with almost any how, right? So having a direction in your life, having something that pushes you forward. And so really the how do you want to be in this world, right? We know what we want to be. We want to be symptom-free, right? That's an easy thing to answer, right? We want our brains back the way that they were. But how can you be in this world, again, with some of these symptoms? And so there's lots of ACT resources. Recently, just last year, the first book came out for actual brain injury. As I said, this is kind of a new field in psychology in general and very new to neurological populations. But these are all some great books. And so again, it's called Acceptance and Commitment Therapy, so ACT, and is relatively new. I'm working on a book. It's not out yet. And so in conclusion, psychological symptoms very common after a TBI, right? And it really does impact recovery and outcomes. And I think you can say that for neurological conditions across the board. If you have that psychological component, it just makes things harder. In terms of the effects of sex and gender, right? Here we're talking about this amalgamation of social, biological, cultural, behavioral elements. It's just largely underappreciated in TBI research. And so we don't know that much yet. And so that really needs to be done better in research. And so it's important to understand what's contributing to psychological symptoms. Like I said, assessment is a really important thing. And, there can be some additional factors with neurological concerns and psychological disorders. And so psychological flexibility might really improve outcomes for individuals who find themselves in these positions. And then finally, we need consistent consideration of the constructs of sex and gender in TBI research, right? It'll help us understand the different mechanisms. These are really, really complex clinical pictures. And so ignoring sex and gender the way that researchers have often in the past is just like this huge, huge hole in our understanding. And then finally, thank you. I've got my email address there. If anybody ever wants to ask me any questions later, I've got my lab website. We've got our publications up there if you'd like to look at them, as well as my clinical website. This is for my therapy and assessment. So thank you very much.
Wonderful. Thank you so much, Maya, for sharing and like amazing research. I especially like noticed the spike in that chart about the TBI prevalence, since I'm in that age group.
Be
Thankfully,
careful.
yeah, thankfully I don't have
Drive slowly.
exactly. And so yeah, now we will answer some questions from the audience. I got some through the chat, so I'll share them now. Let me just find them. One of them being, is multiple sclerosis considered TBI?
That's a great question. So multiple sclerosis is considered a neurological disorder. So it's not an acute TBI in the way that we talk about that traumatic brain injury, right? So from an injury or from an accident. But MS falls very much into what we're talking about here, right? In terms of psychological outcomes. And, you know, MS, the symptoms really are so difficult to live with that people really do get very tied up in them emotionally, with the depression and the anxiety. And so as far as I know, don't think I've seen any ACT studies around psychological flexibility with MS, but I imagine it plays a very, very big role, because it's such a chronic condition that affects so many parts of your life.
Awesome, thank you. And another one, how does dysautonomia present?
So it usually presents as a great question. Actually, let me see if I can pull it up here. And so basically this kind of happens when, so if you don't have PTSD, right? So there's a little bit of crossover with PTSD, but let's say you didn't have a traumatic event, right? And you find that you're like really, really heightened. So you jump at like any kind of sound, but physiological, you actually feel okay in the moment, right? So that might be an indicator of dysautonomia. And so what happens here is that the traumatic brain injury creates overactivation of the sympathetic nervous system, okay? And so that's the one you can see over here on the right. And so the symptoms feel like anxiety, but you don't have the cognitive parts of anxiety. So you're not worrying all the time, right? You're not thinking about all the bad things that are going to happen. You don't feel upset. But your body is acting like you have really profound anxiety. So that's dysautonomia. And so you get increases, your heart might start beating really fast, right? You might have some gastric issues, you know, your pupils might get quite dilated. So all these physical symptoms that we associate with anxiety. But when you look at your own thinking, you're like, I feel fine, right? I'm not worried about anything. I'm not scared right now. I don't know why this is happening. And so it basically, the brain injury from whatever it came from, pushed your body over to that sympathetic side. And that's usually treated more with medication than therapy. So hopefully that helps.
Okay, thank you. And yeah, just one more question. So you mentioned how individuals suffering from grief are different from those with hormonal imbalances when assessing depression. And I assumed that grief could consequently cause the hormonal imbalances. Is this a wrong assumption then?
Yeah, that's a great question. So usually the big hormone imbalances that we see post neuronal injury is because there's actually damage to that part of the brain. So either through the stroke or maybe the TBI, there was damage to the pituitary gland, something like that. And so you get these really big hormone dysfunction. With depression, sometimes you can see hormone dysfunction, right? But it's usually the depression doesn't cause the hormone dysfunction. It's usually the hormone dysfunction actually causes the depression. And so usually that's when we see like thyroid disruption. So people with hypothyroidism, for example, so they have low thyroid production, that causes depression. And again, it's quite different from other depression because that one we need to treat medically, right? Or sorry, not medically, but with medication. We need to get your thyroid functioning better, right? And so therapy tends to be a little bit less effective there.
Okay, makes sense. And we have a few more in the chat coming through. So, is it possible that a serious concussion as a young person could be the cause of addiction to alcohol in later life? Just shared here, our nephew was hospitalized at 14 years old from a bad fall from his bike, and now 40, very addicted to alcohol.
Yeah, it's such a good question. It's considered a risk factor. Right. And so it's really hard to point one of these to, especially for addiction, to point one thing to one outcome. However, we know that something like a concussion can impact impulsivity, cognitive function, right? So maybe you're making poor decisions, right, which can lead you to addiction. It causes emotional disruption, like we talked about in this talk. And so a lot of people use alcohol as a means to cope with that, right? Very, very common. And so it's probably not a complete cause and effect. A lot of things in the middle there, but it is a risk factor, right? So if you have a head injury earlier in life, especially at young ages, people who experience those injuries do seem at higher risk for addiction disorders.
Okay, and one over here, are the effects of DBS considered TBI?
Not usually. So again, similar to MS, it's not, so the traumatic injury is really something smacked you in the head, right? That's my clinical term, right? So something really hit you in the head or shook your head like this. And so there's a lot of, again, these more chronic neurological conditions, right? Medical conditions where everything we talked about still applies, but we just don't use the term traumatic brain injury.
Wonderful. And just one last question. As a caregiver or someone around those with TBI, what are ways we can support them?
Absolutely, such a good question. And I mean, luckily now we're doing more research on caregiver, both aid and burnout, right? Very, very difficult to be a caregiver. And a lot of actually the psychological techniques we talked about today are applicable to caregivers too, right? Who can suffer from things like anxiety and depression just because it's such a big responsibility, such a big thing in your day-to-day life. So as a caregiver, again, really encouraging kind of this detached view of your symptoms, right? So if you can create space, right? Ask the person about like, what would be a great thing to do today, even though you have pain, right? What would you enjoy, right? And kind of starting to introduce this idea that you can have both at the same time, right? So you can have pain, you can have symptoms, and you can do something that you enjoy. It might not be to the full capacity that you could before, but maybe we can get some snippets of it, right? How can we get you aligned with your values, right? If you're someone who enjoys, who has a strong value of caring, right? Even small things, plants, right? You can care for a plant. There've been amazing research where they took plants and introduced them into nursing homes, and the residents did so much better because it aligned with some of their values around caregiving, right? And so really kind of taking the time to understand the person's values, right, to introduce some of that psychological flexibility so that people don't get quite as caught up in their thoughts and symptoms and kind of those negative aspects of the disorder.
Okay, wonderful. Yes, thank you so much. This was an amazing presentation. Yeah, if anyone wants to ask further questions, we have Maya's contact there. And yeah, so that's all the time we have for today. Thank you so much again for sharing your expertise.
It's such a pleasure. I really appreciate it.
And yeah, and thank you so much for everyone joining today. I hope you all were able to learn something new today. And we will see you next month for our Wellness Wednesday.